Hi, good morning, everyone. Appreciate everybody's participation here. Very exciting webinar we have today. And Rethinking CDI and Compliance is the title. A little bit about XDion, a technology solution company, certainly leading with AI as it relates to coding, billing, and revenue cycle management, reshaping how to eliminate denials, optimize revenue, and maintain compliance. And the webinar today really about empowering providers and preventing any revenue risk. And really, this is a strategic session as it relates to chief medical officers, medical directors, clinical documentation improvement leaders, groups, compliance managers, and then RCM leaders. And speaking of leaders, I do want to introduce our guest, very well distinguished emergency and urgent care physician, clinical ultrasound expert. He's on the board of directors at Naruka and XDion Health's clinical advisor, Dr. Rajesh Garia. All right, everybody. That said, let us dive right in and we'll get to it. But if we look at this, really is a growing burden on providers. Is it a crisis in the making? Is it mounting, or are we already there? I think Dr. Garia, if you could be so kind as to really kind of shed some light on clinical documentation improvement, or the emphasis on documentation, the right documentation, and what you guys do day to day would certainly be helpful to kind of kick this off.
Yeah, sure, Mark. First of all, it's a pleasure to be here. I'm really excited to kind of dive into this important topic that oftentimes gets overlooked. So I think I look at this as more of just a discussion. I think this presentation, there's a lot of bullet points. I don't want to bore you guys in reading all these bullets, but I hope it can be a discussion and we can learn something from this. So I think it's important to start off with just painting the picture of what us as providers have to deal with on a daily basis. And that's balancing between speed, efficiency, and accuracy, especially in those busy seasons, the winter seasons, where we're getting slammed with high volumes. Sometimes providers trying to see 5 to 6 patients an hour. Sometimes you're single coverage and your office is seeing 60 to 70 patients in a day. So, of course, documentation is important, but when you're trying to balance these things like procedures, taking care of the patient, sometimes you don't have an X-ray tech, you don't have a medical assistant, so you're drawing blood, you're trying to basically answer phone calls. So all these things take time, and unfortunately, documentation sometimes takes the back seat, when in reality, the documentation should be the most important part, aside from obviously delivering high quality care. But documenting accurately is important for medical legal reasons, from compliance reasons, and most importantly, just shows that you're delivering high quality care. And it paints a picture of what you did that day. You're not going to see the patient again, really. I mean, sometimes they'll come back to the urgent care for a follow-up, but a lot of times you're not going to see them again, and they're going to go to a hospital or a primary care, and they're going to want to see what was done, on prior visits to a healthcare professional. So it's important that we do focus on documentation.
Yeah, I think a lot of the benefit as it relates to documentation is how can we start making that a little bit more empowering for the provider, and what are things that AI can do to kind of help that. And so those, as you kind of talk about your day to day, it sounds like time isn't on our side during the day, because all of these episodic visits, you've got to see 40, 50 patients a day to make a living. So, that can start to stack up, and are there areas that, we could help with, or that can technology help with, and to make sure that we're providing that, or helping, with that level of care that you guys are providing.
Yeah, and that's the key. We have a workflow, and anything that interrupts workflow, the more clicks that we have to do. Sometimes, we're just burdened, we're weighed down by all these things that we have to do to actually, get the right documentation in the chart. A lot of times we get the feedback on documentation, if we get any at all, but that's given after the patient is gone. And, that's the last thing I'm doing on my day off, is try to figure out and remember what I did with a patient, a week ago.
Right.
So anything that can be integrated into these busy workflows would be extremely beneficial.
Yeah, I agree. Let's go to the next slide, and we talk about, what is the result of what is happening with this potential crisis, if not already a crisis. But, the burnout has been, I heard it at the Delegates Council, or, this was last year, and, burnout, physician burnout, provider burnout has just been a nonstop topic. And, so I know there are groups out there that say, hey, it's just 2 more clicks, right? Well, you're getting clicked to death, right? And it's taking a lot of time. So how do we remove those clicks and really try to provide some relevant data or information that allows you to make a more informed decision? So, but without risking compliance, right? We want to make sure we're maintaining that. But as an operator, we also want to maximize or optimize reimbursement. So, because I would argue at some point it's providing better treatment plans, because you have more document or the right documentation in there that allows you to create that treatment plan. Is that something that sounds right or no?
That's very true. And I think that's the issue, is that when we're moving at these fast paced, things are, sometimes things are left out, and those are important things, right? So you're so busy trying to, suture the laceration and, get to the next 5 patients in the waiting room, that, you may forget some key components of the complexity of the case, or, the comorbidities the patient has, or is this an acute issue? Is it a chronic issue? Your laceration, was a simple repair, a complex repair? What was the guy, had a chest pain? What was the differential diagnosis of chest pain? Did you actually think about that? And if you didn't document any of that stuff, you didn't think about it, so that, it's basically how it's looked at when the chart's audited, right? So those things are key. And I think that anything you can do to help streamline that, like on the spot point of care feedback, prompts, where, you type in a certain diagnosis, and, a couple of questions pop up as prompting you, like, is this acute or chronic? Is this, did you think about this differential? Those things help. And it helps, because it's on the spot.
Yeah, and I think, you look at the evolution of all of these tech companies that have these point solutions, that solve a problem. But then, we try to fix as much as we can upstream, right? So we don't have that on the downstream side. And, the some of the technology that can be deployed is, Exdion has real-time check, where, you are looking at the data right in front of you during the visit to say, hey, have you done this? Did you take blood pressure? Whatever the case may be, because it's also capturing on the back end, maybe something I did miss, or hey, prescribe 2 Zofran, I'll put it in the chart later, and that doesn't get put in. Those are the things that technology can catch. And that's where I think we've got a benefit for the provider, to help empower them, because they can't think of everything. They're trying to provide the best care. So, something that might be beneficial.
Exactly.
And in terms of and incorporating into your workflow, as you mentioned.
Yeah, I mean, just something, it's something as simple as, like, you forgot the vital signs, or, things like that, or the allergies to the medications, or, are there any interactions with other medications they're on? Sometimes these things just fall through the cracks, and that creates a huge safety issue. And of course, compliance with protocols. So any type of tools that can assist us in that, help us help us not burn out. Let's put it that way. A lot
Yeah.
of us are getting toasty, and we're looking. As much as we fear this AI, is taking everything over. I think I look at it differently. I think it is something we need to embrace, and use it as something that can actually help us deliver better care. So
Yeah, for sure. No, I agree. Because it's here, right? I mean, it's not going anywhere. It's just evolving. Yeah. All right. So if we look at, clinical documentation improvement, here it says not just a coding function, which, I think this kind of dovetails into, yeah, we know it's not a coding function. It's all about documentation, but how is that documentation getting coded? And if things are missed, how are those items captured if something is missed? And then how are we educating the provider down the road, right? So maybe talk through what you've seen, what is out there, what you like, what you don't like, and see if I can fill in any gaps.
Yeah, I think there's a huge need for more education providers on this. I mean, this is not something that is focused on much in medical school or PA school or nursing school, so we're kind of learning on the fly here, and I think the onus is on these leaders in the urgent care realm to engage the providers, and not just once every 3 months, once every 6 months. Hey, here's your feedback.
Yeah.
I envision this as something maybe at least quarterly, I would say monthly, and you know, very concrete. Here's a dashboard, and here's all the providers in the group, and here's where you fall.
Yeah.
And are you at the lower end? Are you at the higher end? So, and then you can kind of identify certain trends. You're consistently leaving out the rapid strep on these pharyngitis patients, or you're not documenting a differential diagnosis of chest pain. So, or the, is this an acute or chronic asthma, or is it intermittent asthma? Is it severe asthma? So those are the things, or maybe the procedural things. That's a huge area, right? So you're not, doing simple versus complex, or the size of it, so all of those things, that provides incredible value, I think, for providers, that they feel like they're more, they got skin in the game now, so they can see, okay, so I'm at the top of the group now, and so the patients I'm seeing are getting higher level care, but we're getting higher reimbursement for our group because of what I'm charting, so
Yeah.
they want to feel like they're important, they're valued, they're involved. And that's some things that are left out. I go to many urgent care conferences every year, and these are things I hear time and time again, that there's no transparency, there's no engagement with the providers, and that leads to burnout. And then ultimately that leads to poor patient care and a poor patient experience as well.
Yeah.
So
Net promoter score is going down. Yeah, it's tough.
it goes down. And, I think, we all different urgent cares do this in different ways, but there are metrics that are looked at pretty heavily, patients per hour, patient satisfaction, chart closure. Those are some examples, and all of those things calculate into a bonus. And so, you'll get a quarterly bonus based on that. And I think, documentation should be part of that bonus. I think that, having some tools and some data that shows how effective you are, how accurate you are in your documentation. If you're at the top of the group, there should be some monetary compensation, for the providers for going that extra mile. And so I think having that transparency will help that.
Yeah, and I mean, that boils back down to, what you said about getting their buy-in, right? I mean, there's now they're feeling a part of that process, and not just another. I think you mentioned this the other day. We were talking like a cog in the wheel, right?
Mhm.
Yeah. So
Yeah, I mean,
good
all too
points.
often we feel like we're just, when these busy volumes, it feels like you're working in a factory, right? And it's just like, just going through the motions. And when you start getting to that phase, it's game over, And I
Yeah.
think this is an opportunity for real connection with the providers by talking about documentation
Yeah,
improvement.
I think if, we've talked to a few groups and some groups of XDON that have, you know, one of the tools that really calls out. It's more tactical education. So, provider A may be really good at code or documenting respiratory, but they're having some issue in another area like orthopedic or whatever the case may be. Well, now we've got tactical education because they want to be in that top range. I mean, who doesn't want to be in the top range, because they're arguably providing better patient care. So, those are the things that I think are, and to your point earlier about, having a dashboard that says, hey, here's what we're doing well, here's where we need some work, and here's where we can always do better. And so out of that, having those tools at your fingertips, and then that education, that repetitive education process is just really elevating the field in the provider game, if that makes sense.
And I think that, I work in the hospital as well. I work in the emergency department. You know, at every staff meeting, there's a handout, and you can see where you stand as far as, patients per hour, RVUs. You can compare yourself to others. And I think that lights a fire, right? If you're at the bottom of the patient satisfaction, you're also taking the longest to see the patients, or whatever it is. It's changed. I think that kind of changes behavior.
Yeah.
Like when I go work out, I go to Orange Theory. It's a high intensity fitness, right? I'm running on the treadmill. I can see everybody's stats in the room on the screen,
Wow.
right? And if I'm at the lowest, I start running faster. It's just human behavior, So
Yeah.
so yeah, I think that's important.
For sure. All right, let's go to the next one. All right, so as we're migrating, we're going from compliance to confidence. What does that tell you as a clinician? I know historically we've seen metrics where providers are documenting, and not necessarily that it's what they're doing, but the coding is more safe, if you will. It's not accurate, and so they're putting in enough documentation to satisfy the chart, but then it's being coded, or however that's being interpreted is coded, maybe safely, so as to avoid any type of recoupment or any blowback. And as I always preach, I've heard you say it is about doing the right work or the right documentation. Let's maximize or optimize profitability for the company, so we can grow and excel. What are your thoughts?
I agree. I think there's so much of this stuff that I'm learning as I go still, and I've been practicing 25 years. And it's just, you know, forget about the simple things like, doing a complete exam and, including vital signs and allergies to medications, things like that. But, just things like documenting the severity and the comorbidities of the patient, can lead to a dramatic difference in reimbursement. And once you start learning those things, for example, just take asthma. There's a big difference between mild persistent asthma and moderate asthma, right? It's about, okay, I'm only using my inhaler twice a week, and otherwise I'm okay. Whereas, moderate, I'm using my inhalers every day, sometimes 4 to 5 times a day. And now I'm falling into a complete different category. And that translates to, if you're documenting that accordingly, you're going to get paid, higher for that. You're going to get more reimbursement. There's this whole, thing called healthcare costs hierarchical condition category, HCC, which basically, not all healthcare dollars are distributed equally. And so if your chart reflects HCC, so you're, documenting why this patient fits a moderate asthma versus an intermittent, that equals more healthcare dollars coming to your clinic. So this is not stuff that we think about, when we're trying to see 5-6 patients a day, right? We're just,
Right. Sure.
and sometimes we're using scribes to write our charts, and they're leaving a lot of stuff out so that we can be more efficient. But are they really documenting everything that needs to be documented? How much time do we have to review their documentation?
Yeah.
And so that's the thing. So any of these things that the AI engine or any technology can do for us and prompt me when I have an asthma patient, hey, did you think this patient falls into the moderate versus intermittent? This is the last thing I'm thinking about when I'm seeing asthma patients, and I'm just like, okay, I made them feel better. I gave them an inhaler. I'm giving them steroids. Bye. I'm diagnosed asthma, So I think this just opens up a whole new avenue of generating more reimbursement and also delivering higher quality care. Because this patient with asthma is now going to leave the clinic. You're never going to see them again. They're going to go to a pulmonologist, and the pulmonologist is going to want to see what was exactly done for this patient. So it just translates to better care long term.
Yeah. Yeah. And I mean, I was looking at this last bullet here. It says, tying documentation back to denial prevention and quality scoring. You know more about the quality side. I probably know more about the denial and how to rework a claim. But, out of that, what are some of the quality metrics that they're scoring as it relates to documentation? Are they looking for anything specific, or, what are some of those things? Or is that different by
Yeah,
urgent care?
that's exactly what I was saying is, they're looking at, did you really, how can you justify the care that you gave,
Gotcha.
like,
Yeah.
so you prescribed an antibiotic, for sinusitis, right? So why is that? Why did you do that? Your chart doesn't reflect that. You said
Okay.
sinusitis. That can be viral. That can be, so they didn't, you really deviated from the standard of care, and they take antibiotic stewardship very seriously. So you have to say bacterial sinusitis, right? So like, you need to use the right terminology to justify the treatments you're providing and the care that you're doing. Did you think about, I think key things are really just the complexity of the care, complexity of the case, the comorbidities. What I found is that the sicker the patients, the more chronic illnesses they have, you have higher opportunity for reimbursement at higher levels if you can document that.
Yeah.
So you have the 80-year-old comes in with a cough. It's much different. An 80-year-old with COPD is coming into the clinic with a cough is much different than a 22-year-old coming in with a cough.
Yeah.
So you have to leverage that and use that. So those are some of the things that translate to, denials or more reimbursement. I think just.
Oh, no, for sure. Okay. All right, let's go to engaging the provider voice. Now, you know, I've, I listen to you, other physicians, providers, in the market or in urgent care, and I hear burnout a lot, right? But I want to hear, what are some of the things that would enhance, the provider experience, if you will, or the clinician journey on that patient visit. Let me put it that way.
I think there are several things there. I think, like I said before about the workflow and just keeping it
Yeah.
integrated, that's everything, right? So if I'm seeing a patient and they come in with, let's say, chest pain, um, I get a pop-up that says, did you think about this differential diagnosis? And
Okay.
if so, do you want to integrate that into the chart? Yes, I do. So that shows that you thought about a differential diagnosis. If there are any tests related to that, to make sure that that was, put into the chart. So EKG, did you think about their risk factors for a cardiac etiology of chest pain? So, oh, well, I didn't really think about that. So let me put that in there. So these are all, and these should be point of care. I think point of care is
Yeah.
the point I want to hammer across the most here is that, it doesn't do me any good. The patient leaves the clinic and then I get an email, 4 days later saying, hey, can you go back into the chart and adjust these things? Because I may be on my day off. I may forgot that patient and life is busy and I don't think, that's a practical avenue to address these things. So I think on the spot point of care nudges while you're documenting would help the most. And then I think the overall transparency of the process, having the
Yeah.
providers engaged where you would get, monthly feedback, not just a printout, but, you may get a phone call or a session with an expert in this within the group, or maybe someone from a company like Extion, that you can go over all your charts and or some of the key points that you're lacking in your documentation, and then kind of follow up and see how you're improving on that. I think that helps a lot.
Yeah.
And
Moving
then
up the
when
ranks on that dashboard that you
yeah,
mentioned.
and then eventually providers get more confidence in this, and then they become leaders within their own groups of that. So I think that's a cool thing as well. So yeah, less clicks, more on point of care prompts. I think education, a lot of, like I said, we didn't learn a lot of this in med school or PA or nursing school. So
Yeah.
the more education, the better. Maybe we can tie some of this to CME as well, because I think it's a valuable learning opportunity. So it should be linked to some sort of CME. And I think that would drive more interest as well. But yeah, I think that would get more engagement.
Yeah, I mean, so hearing that voice kind of ties to, when you say point of care into the workflow, and just the benefit of understanding because you guys are immersed in it, you're in it day to day. So, talking to the front lines about, how can that help? How can technology help, like you had explained? So,
Mhm.
I think that's very beneficial for, anybody. And to your point about CME, that's a little bit more involvement in terms of if I am doing this and I am getting CE credit, that shows you how valuable the clinical documentation improvement is in the workspace. So,
Yeah, and I think that's just one more way to get buy-in. CME is one thing, but I think more than that would be just aligning this with the paper for the pay for performance, like as part of your
mhm.
bonus. Like if your bonus has key metrics like patients per hour, patient satisfaction, I don't see why documentation metrics should not be included in that. And I think that's, money talks, and I think that would dramatically improve buy-in and improve documentation as well. Um, because there's a lot of that going on where the providers are just sitting there feeling like they're just factory workers and thinking like these guys, guys or gals at the top are just raking in all the money and just, they're just not feeling it part of the equation. So I think that that's something that the leaders need to think about.
Yeah, yeah, good point. All right, now using AI to reinforce, not replace. Big stigma around AI. I'll just get your thoughts kind of as a whole on AI, and then we can kind of drill into some examples of how AI has helped with other clinics in terms of CDI, clinical documentation improvement.
Yeah, I mean, I'm not gonna lie, AI has a very bad stigma in the medical community as far as from the provider level.
Sure.
There's a lot of fear, that AI is going to take over, multiple specialties, and we're not going to have jobs when we graduate medical school after all these loans we pay, and all these things. So and it's not only medicine, it's every field, really. I have a
Yeah.
kid who's going to college, and we're just like, is he gonna even have a job when he graduates? Like half of these jobs are going to be eliminated by AI. But the more you dive into it and really think about it, it's, these are tools are designed to, improve your processes and help you and assist you to be better at what you're trained to do. No one's going to replace, AI is not going to be, doing bedside manner, and it's something that's still on you to have good bedside manner, right? So I try to look at it as that, as something that's a tool that's not going anywhere. It's here to stay. We need to embrace it and use it for what it's good at, and that's just making us more efficient, and not replacing our clinical judgment, but augmenting it as well.
Yeah. And let's be clear, you don't look like you're old enough to have kids in college.
Thank you. Thank you. Yeah.
I don't see one
Well, I'm
wrinkle.
getting older.
Um,
It's my
hmm.
birthday, so yeah.
Today's your birthday?
No, not today. It's coming up
Oh,
end of the
whoa,
month.
man.
So
All right.
yeah, yeah,
Happy
getting
birthday.
older.
So your birthday when Naruka is happening.
Right. Naruka,
Got it.
yes. Can celebrate there.
Mental note.
Right.
Got
Right.
it. All right. So yeah, I think AI, in terms of empowering the provider is really what's at stake, and how can we get that message to make that clear, versus replacement. And that's like you said, it's there's a stigma around it, and it's not the best of stigmas. If there is such a good thing as a stigma. So that being said, I think that there's a benefit to education, to if you're in it and you're learning it, then that is a little bit better absorbed versus, not getting anywhere close to it and fighting it because, as we said early on, it's here, it's not going anywhere. It's always evolving, right? They're trying to find, and by they, meaning everybody's trying to find ways to really let AI help. So yeah, it's difficult conversation, but certainly warranted and needs to be addressed. Yeah. All right. We are cruising, man. We're only 30 minutes in and we've got one more slide. So this last slide says the future of clinician-led RCM is really meant by my perspective is really about, that documentation that is constantly improving that, folks are being educated on really starts at that level in terms of any revenue cycle management that needs to be done on the back end and how we are optimizing revenue, how we are maintaining compliance, how we're reducing denials, and all of that can be done, on the front end to try to prevent anything on the back end. So, that was the statement about empowering the clinician really in terms of documenting better allows the coding to be optimized, cleaner, reducing those denials and rejections, and really helping on the back end. So just kind of a testament to the good work you guys are doing, and then how we can help from a coding perspective.
And I think it's important to realize, as far as urgent care specifically, the RCM, it's important to do that up front because unlike hospitals where the patient's admitted and, they're there for 2-3 days, you have some time to clean up the charts. And, in urgent care, it's like on the spot, I see this patient, they're gone, and, I might not see them again. So
Yeah.
the chart needs to be like audit ready as soon as the patient is discharged and as soon as that chart is signed.
Yeah.
And so that's where, a lot of the benefit comes from having these tools.
Yeah. Yeah, exactly. So, whether it's during the visit or directly after, being able to get these prompts that says, hey, based on this documentation, we've seen XYZ. Did you do A, B, and C? If you did, great, put it in the chart. Now, to your point earlier, 4 days down the road, I'm not going to remember. You've got it fresh right there, right after the visit, and can get that data, theoretically real time, depending on EMR. That integration is capable of doing it real time while it's in the visit. Otherwise, it's post facto, depending on whenever the system updates or refreshes, that you would have that data while you're having a cup of coffee in between patients or whatever the case. So
yeah,
very good benefit there. Any other thoughts on any of these bullet points?
no, I think it hits all of the things we discussed. I think the most important thing after all this is said and done is that whoever picks up this chart needs to be able to understand the patient's true story. Like, what is their story? And you need to have a clear idea. And the only way to get a clear idea of that story is to have bulletproof documentation, because these patients, they may go to like 3 urgent cares in one day. They might go to urgent care, and then tomorrow they're in the ER, and then 3 days later they're in a specialist. So, rather than, and we do this often, is we're just ordering repeat labs and repeat imaging, and so these things add up to the medical costs of the patient, and has to endure, but also our healthcare system has to endure. So, by having accurate documentation, we can kind of save on some healthcare costs as well.
Yeah.
So,
Understood. Okay. We've got this last slide. Any questions anyone has You could put those in the Q&A. We have some time for Q&A, but if you scan this barcode, it's got my contact information on it as a way to get a hold of me. Any questions that we don't get to today, the chat I think has been disabled, but you can post questions in the Q&A side, and we'll read those and get those answered. If we've ended and you think of a question, reach out to me. We'll make sure Dr. Garia can get us some answers to it if needed. Or if you have anything about XDion or have questions about it, certainly let me know, and happy to field those as well. All right. Don't see any questions in the Q&A as of now. All right. Everybody get about 20, 25 minutes back on their calendar. And
Sufficient.
yeah, very. No, this was great and enlightening. I really appreciate your time, Dr. Garia. Always a pleasure. Look forward to seeing you at Naruka and the rest of the Naruka team, and any groups that have any questions, reach out and look forward to next steps here.
Yeah, and if anybody, you have providers in your group that are, curious about this kind of stuff or documentation or AI in general, or even urgent care practice as anything about urgent care practice, I've been doing it for a long time. So, I'm willing to have those discussions. Just reach out to Mark, and then we'll go from there.
Yeah, sounds great. Well, thanks again for the time, and I'll send out a note about the recording of this webinar. So if you want it, certainly happy to provide that, and appreciate everyone's time. Thanks so much.
Thank you, Mark. Thanks, everybody.
Thank you. Bye, guys.